All right. Well, good morning, good afternoon, wherever you are located. We're very happy to have you here today. I am Christina Clayton, one of the co-directors for the Northwest Mental Health Technology Transfer Center. Welcome to today's webinar, Grief, Exhaustion, and Finding Vitality in Behavioral Healthcare for Staff Doing Direct Services and that other kind of direct work with Dr. Kyra Mosseth. We're very grateful so many of you could join us. And then really want to first start with our land acknowledgement. We ask for those who are on this event to reflect on the lands in which we reside and acknowledge these ancestral homelands and traditional territories of Indigenous people who have been here since time immemorial. We want to acknowledge the land, pay our respect to those Indigenous nations whose homelands were forcibly taken over and inhabited. This calls us to commit to forever learn how to be better stewards of these lands through action, advocacy, support, and education. We'll put in the chat this link. It's a great resource from Native Land if you want to learn more about the stewards of your land. Thank you so much, and we will go into our network introduction. The MHTC Network, if you haven't been on one of our events before, is a nationwide network that is supported by the Substance Abuse and Mental Health Services Administration, or SAMHSA. And our network includes 10 regional centers, a National American Indian Alaska Native Center, a National Hispanic and Latino Center, and a network coordinating office. And if you haven't heard, there have been an addiction similar structure in place for about 27 years. And the prevention started around the same time we did in 2018. We support resource development, training and technical assistance, and those kinds of things into the field. And we work with anyone whose work has the capacity to improve the lives of people living and recovering from serious mental health issues. Our specific region covers Region 10, which includes Alaska, Idaho, Oregon, and Washington. And our center is based in Seattle in the University of Washington in the Department of Psychiatry and Behavioral Sciences. Now a little bit more about our Northwest Center. So our goals are essentially listed here to accelerate adoption and implementation of mental health related evidence-based practices, heighten awareness, knowledge, and skills of the workforce, foster alliances and address training needs among diverse partners, and ensure availability and delivery of free publicly available training and TA like today. So our area of focus for the network is evidence-based practices for serious mental health issues such as psychosis. So you'll hear a lot from us around assertive community treatment or cognitive behavioral therapy for psychosis. However, like today, we provide training on a variety of topics. We also, in addition to live events and recordings, we provide monthly newsletters where you'd hear about events like today, resource library, tip sheets, and other on-demand content. So if you want to find out more about us, you can go to our website and sign up for our newsletter or follow us on social media. A little bit about language. I think this is very important. Our network actually decided to have a slide like this in all of our presentations because we really want to have the intention to be mindful of using language that promotes recovery and is culturally appropriate. So we just encourage everyone to use language that demonstrates respect for a person's dignity and worth. Next, a few logistics. So due to the large audience, you're muted, you're not appearing on video. This presentation will be recorded. The recording and the slides will be made available on our website. And in fact, the slides are available now. So I think our fantastic project manager, Gabriel, will throw that link into the chat in just a little bit. You'll also receive an email from Zoom with a link to where we put all our archived webinars. And so you'll get to go back and find that when you would like to, or if you want to share it with others. You'll also receive an email within a couple of weeks on how to access a certificate of attendance. There aren't formal CEUs available, but this often can be used to apply for those things, depending on your state and license. So in Zoom, I'm sure you're pretty zoomed out like a lot of us, but we do have both chat and Q&A enabled because it's a webinar. So the chat is really for if you're experiencing a tech issue, you need help from our staff, you want to say hi, share your location. I know people have been doing that. Or if you need to chat your answer to a poll because something's wonky with the platform. If you have a content related question, we need you to put it in the Q&A box because we can't copy and paste it in there for you if you put it in the chat. I don't know why. Maybe someone could work on that. But we will be monitoring the Q&A box to facilitate as many questions as we can at the end of the presentation, because I bet Dr. Moseth might answer some of them along the way. But again, we'll do our best to get to those questions. We do have a habit routinely of doing a Q&A and resource document after each of these events. And so if we don't have an answer for you today, or we don't get to your question, we'll ask Dr. Moseth to help us out and be able to share that with you. Lastly, really fun stuff, but I'll start with the better part. Your feedback is so crucial to our work. We are required to do this very short. It'll literally take you 2 minutes to just evaluate today's session. It's anonymous, confidential. We don't ever see them other than aggregate form, but it really helps the presenters and our center know, did this land well? Was it important to you? Was it helpful? And that's also really helpful. And then, there's clearly a disclaimer. SAMHSA provides us funding, but they are not in charge of, the content and do not have, an investment or, these are not their opinions. But thanks for doing the evaluation. It helps keep our free training coming. All right, now to the good stuff. Want to just welcome again Dr. Moseth, Kyra, as we sometimes call her. She is a practicing clinical psychologist who splits her professional time between seeing patients at Snohomish Psychology Associates, teaching as a senior instructor at Seattle University, and serving as a co-lead for the behavioral health strike team for the Washington State Department of Health. Seems like a reasonable person to have come talk about these topics today. She also serves on the state's Disaster Medical Advisory Committee. Her work and research interests focus on resilience, recovery from trauma, as well as disaster behavioral health. She has also worked abroad extensively in disaster response with first responders and healthcare workers throughout the United States and elsewhere. Dr. Moseth also conducts training and provides presentations to organizations and educational groups about disaster preparedness and resilience building within local communities. So I think we'll welcome Kyra. Make sure you're on camera. There you are. I have a lot of screens going on here. Sorry if I look. Yeah, so we're so glad to have you here again. So we're going to have a little conversation and then we'll go on with the material, but we just wanted to, I'm going to stop my screen sharing so we can see more of you. So as far as this conversation around grief, loss, vitality, many of us have faced grief and loss due to COVID-19 and other life events that have been going along. In your opinion, how does a personal experience of grief or loss or bereavement impact our professional work, especially now in this third year of the pandemic?
Yeah, that's a great question. Hi, everybody. I'm really happy to be sharing information with you and talking to you all today about our sort of collective work in this field. And starting off with a question about grief and loss like that really, I think is a good indicator of the extent to which all of us have experienced some degree of loss. And I think that the way that our personal experiences impact our work in this field sometimes are surprising. We might not be expecting our reactions to certain stories or to the experiences of clients and patients to affect us the way that they do. And I actually had a colleague who phrased it incredibly well, I think. She said that any loss that we experience right now is likely to touch on a deeper well of loss that's been building over the last 2 years. So our responses and our emotional reactions are likely to be proportionally strong to the fact that it's not just that one thing, but it's representing and building from such a long period of time. And that definitely adds up. It affects our ability to sort of try to remain neutral in certain contexts, to remain more objective about what our clients' experiences are. So I don't think it's reasonable to expect ourselves as providers to really separate out those two things right now.
Thank you. And you've been doing this work for a while. What is one, or however you would phrase it, a misconception perhaps about grief, loss, or bereavement that you'd like to clear up, especially as it relates to folks doing direct care work?
Right. There are really two that come to mind, especially in the context of the pandemic and with COVID. Number one is that loss and grief and bereavement doesn't always have to be about the loss of a loved one or a person. there are so many different types of loss, and it's not a game of relativism, right? Loss is loss, and people experience things very differently. And so when we talk about grief, I mean, I think our brain first goes to the loss of a loved one as a person who's missing in our lives, but that's often and not always the case. Losses can be financial or social or sort of systemic in a sense of security, like a loss of sense of security and safety throughout this experience. So those are all losses as well. And I think one of the general misconceptions is that if you're not talking about the loss of a person, then it's sort of not the same thing, when in fact, at least on a very basic neurological and biological level, it absolutely can be. And then another misconception that I have seen and worked with a lot, especially across different cultures and internationally, is that, of course, there are different norms for how grief and bereavement is processed based on tradition and certain rituals that take place. But I think one of the misconceptions that adults have is that we need to somehow either exclude children or protect them by not giving them appropriate information. Now, I acknowledge completely that the way you do that varies dramatically by culture. There are different expectations about the way children are involved with grief and loss, but generally speaking, it's very, very important to give children and youth developmentally appropriate information that is as accurate as it can be about what's actually going on. The tendency of a child's brain to sort of make up something that's worse than what has actually happened or blame themselves in some way. We do our best. We try to protect kids, but sometimes in doing that, we might actually make it a little bit more challenging for them. So I would encourage folks to include children in traditions and in rituals and whatever those grief and loss processes are for your family that makes sense in that context, because they need to be included in those kinds of things. So, yeah.
No, I've heard that from just even parents, and they're just noticing a lot of things are different with the children, and how could it not be after this long? So this is a complex question, so I don't expect you can answer it in just a few sentences, but it strikes me, as we know, the pandemic has shed a light on so many pre-existing disparities, whether that's just racism, rampant, all sorts of, oppressive ways our society doesn't include everyone in the same way. So how do issues of equity and inclusion affect grief and vitality for especially those doing frontline work, doing direct services, the folks that, my understanding, who I've talked to, they didn't have the luxury like some of us to work from home. They were already doing so many difficult roles, and it's harder than ever. And so how does that come into play when this is already, these are things that were here before, right? So
exactly. And I think you make a really good point about how complex this issue is. When we look at behavioral health functioning right now at this point in the disaster, we really are looking at three different kinds of things. And the first thing, the most fundamental thing, is what was life like prior to COVID, right? In what ways were you experiencing privilege or marginalization or discrimination? Like, how did that look for you, and what was your personal experience? Then you enter into this pandemic experience, and you have primary COVID impacts, and you also have secondary impacts. And what you were saying about the spotlight, I say that a lot. Like, disasters shine a big spotlight on social and systemic inequities that exist. It just makes everything come into relief. This is part of the reason for the Great Resignation. People have a chance to see, like, wait a minute, what is happening? What am I doing? And do I have other options here? And they're going to sometimes take advantage of some of those things if they have the ability to do so. But at the end of the day, issues around racism and the systemic, significant problems that were really negatively impacting people's lives prior to this are likely to be sort of enhanced, and in many cases made worse by the experience of the last 2 years. Now, having said that, adversity, when it's in the moderate to mild amount, is protective for people, right? And oftentimes racism, discrimination, and marginalization is not, it's not mild or moderate. These are some severe things that can result in trauma for people. So it really is very, very interpersonally and personally dependent on that person's family experience, their community experience, to what extent they have support for the things that they've been going through. So the way that it plays out in our work as behavioral health providers is that, what my baseline for what I was managing prior to the pandemic is different from yours, is different from the next person's, and so forth. And really, part of our collective recovery is going to be around, engaging a little bit more awareness about these different experiences that are contributing to symptoms and adversity management and resilience and things. And it's not the same set of ingredients that people are working from right now. When we have that awareness, we can sort of be a little bit more strategic about bringing as many of us as we can, like helping us become collectively on this resilience pathway, knowing that my set of resources are different, right, than somebody else's may be. And it starts with that awareness. It starts with an awareness of what the baselines are that you are managing and how you can, if possible, leverage privilege and things like that to support people who might be at a different place with their baseline prior to a disaster like this unfolding. So it's complicated and it's multi-layered, but I see it also, I try to be more objective about this as I can, but I see the potential, which is why this talk today is called Vitality. I see the potential for our collective recovery when we engage in all of this together as being very, very strong. So big potential for shaping and being more mindful of how we do behavioral health care very intentionally. Sanctuary trauma has become something. I'm going to discuss that later with regard to equity and inclusion as well. But we have choices now because of this disaster that allow us to leave things behind and intentionally shape how we want to do this work that is more inclusive moving forward.
Thank you. I know we could talk about that for a long time. Yeah. I'm glad this is just a spontaneous thing that's coming to me now. And I'm wondering if people have time to hear my question and maybe chat into the chat box. I was thinking to ask if people are leaving the field that why. But I think we already know the answer to that. So maybe if you're willing, if everyone on the call is willing, I'm personally very interested in hearing this, and from our center's perspective, what's keeping you in this field right now, and so what's the positive? So if you want to throw that in the chat, we're going to be able to grab that and be able to sort of cobble that together in some sort of way. But I really am wondering, what's feeling good to you today? What's keeping you in your job? Because there are, as you said, the great resignation, the big quit. We didn't join this field. I didn't for the money and the glamour. We have other motivations. But I think you're 100% right. What are the things still driving us to stay in this field right now? And I think it is that hopeful, look at vitality in the future. So I'll get to my last question, then we'll look at you too on the rest of your material. So is resilience and vitality sort of the other side of the coin from grief and loss? And how do you see this all fitting together for us to move forward despite all the challenges? So love what people are putting in the chat. Feel free to keep going or do it anytime later, but I'm really happy to see people have some things holding out hope for them.
Yeah, the examples coming up in the chat are really amazing. And it's very motivating. The things that you're listing are all of the ingredients of resilience that we're going to be talking about today. Connecting with one person, having one moment, having those incredible interactions that just give us that little bit of energy to keep going to the next set of appointments or whatever is on the schedule. It doesn't matter how small scale they are, because it's so meaningful when we have those important interactions with colleagues and with clients and patients alike. So really, really great examples coming up in the chat. In terms of resilience and vitality being the other side of the coin, I actually don't think that grief and loss they're not opposites with resilience and vitality. They can coexist, and they do coexist together very elegantly in a lot of amazing ways. I saw something the other day that said, you don't have to wait for things to get better in order to be happy. And that really sort of, to me, that resonates with sort of the question that you're asking, is that there's the end of the pandemic will not be televised, right? It's not like there's going to be an event and we'll say, okay, now we're done, and whew, and now what, right? It's not such a marker in time and space. But I think what a quote like that is trying to indicate is that there are ways to find very, very meaningful pieces of vitality and a sense of purpose and really strong resilience throughout this whole process. And it might be on a minute by minute or an hour by hour basis, but it's always there. And so it's not a matter of doing one thing, getting the negative out of the way and healing from that, and then turning the corner and focusing on vitality. Post-traumatic growth is a concept whereby you go through a traumatic event, and sometimes, ideally, that hope and that growth is on the other side, right? But we're talking about a constant sense of transition throughout the last 2 years, and it's not just one and then the other, or you do one thing and then you switch to gears to something else. So the concept of post-traumatic growth tries to address that, I think, a little bit, but I don't see them as being opposite sides of the coin. I see it being all part of the very, very beautiful and challenging human experience that we're living together right now.
Well, thank you so much for this conversation. It has been fantastic to talk about these topics. I want to share a couple of, I was talking with our staff, Gabrielle, who's on the behind the scenes managing everything today. And I thought, we need to start showing something nice or sweet or funny at these calls, because we're so zoomed out and we're so burdened by everything. So I'm going to just, again, very impromptu share a few pictures, because I know that part of keeping our resilience is getting out to see beauty or see things that, aren't part of our daily lives. So I'm just going to share a few pics I had from a recent trip to Florida. So a nice sunset, beautiful outdoor scene, and amazing iguana that I just saw randomly. And then I didn't know there were so many roosters in Florida, just randomly, all sorts of places. So those kept me smiling for those couple of days. And I just wanted to share those because we all need some puppy dogs and fluffy clouds every once in a while before we get back to the hard work. So anyway, I'll turn it over to you, Kyra. Thank you so much. Let you go on with your presentation. Thanks, everybody.
Okay. Thanks, everyone. I will go ahead and jump in and share my screen, get it in presentation mode here really quick. And then please do add your questions to the Q&A, content related questions. I'm going to get to those towards the end of our discussion today. I'm just going to do a little bit of agenda, and then we're going to do our first poll. We have just a couple very brief polls for you all that I think will help sort of orient the direction that we're going to go as a group today. So the content that we're going to try and cover is a little bit of a high level view of current conditions and functional challenges that people are typically experiencing in the workplace. Obviously, everybody's professional and individual experience in this pandemic is going to be very different, but in general, I'm going to share what we know about the way that disasters shape experience in behavioral health. And then I'm going to talk about informational and emotional processing, which are clearly two things that directly are related to the kinds of work that we do when we're providing service to others. I'm going to talk a lot about grief and loss and bereavement, hopefully in a way that is new from other things that you may have heard before, and then shifting those gears and really incorporating the shift from grief and loss, as Christina was just discussing with me, working through it and having vitality and finding resilience at the same time, even when everyone is really, really tired. So that's the plan for today. And I think we're going to go ahead and launch a poll briefly. This question is helpful for me to understand. This is, how familiar are you with the concept of a disaster cascade and its impact? So what is it? What does it do? I'm going to start with this and we'll see what we can get from there. So it's looking like most of you are not at all familiar. There's only a couple folks so far who say they are very familiar, and some are slightly familiar. I'm hoping by the end of today, you will be all very familiar. That's one of the goals that we have. So the poll is, how familiar are you with the concept of a disaster cascade and its impacts? Got about 70% participation. I appreciate it. Thank you all. So most of the audience seems to be either not at all familiar or just slightly familiar with it. Gabrielle, can you go ahead and share the results with everyone? I don't know if it's sharing. I think it is. Can everybody see that? Yeah. Okay, great. I'm going to go ahead and stop it and keep moving on with the talk. Share results. There we go. Oops. Did it get shared? Okay, good. Great. So I'm going to start by sort of normalizing and familiarizing all of us with this disaster science perspective on behavioral health work and support for folks, and where things really tend to get difficult and challenging. So this chart is a chart that was actually created by SAMHSA many, many years ago, and it is based on aggregated data from a variety of disasters over the last 20 or 30 years. So things going back to the tsunami in Southeast Asia, the Fukushima nuclear meltdown in Japan, the earthquake in Haiti, Hurricane Katrina, and 9/11, just to name a few large-scale events. So we have a very, very solid, I should say, an evidence-based understanding of the phases that people go through when we experience a large-scale event. It starts with the impact phase, and that is usually, you know, for the COVID pandemic, it was typically stay-at-home orders, or when we were asked to, you know, not go out at the very beginning when life shifted, and we were told, man, maybe we're going to be asked to stay at home for quite some time here, and we didn't really know. That's what the impact phase was. Obviously, for an earthquake, it's a specific point in time, so the impact phase looks a little different. But then we go into the heroic and the honeymoon phase, which was for most places in the country in the spring of 2020. And that was April, May, maybe even into June, depending on where you are geographically. That's when everybody was watching the Tiger King and hoarding toilet paper kind of nationally as themes. But that was also when a lot of celebrities were posting inspirational videos and trying to come from a place of, we're in this together, that sort of mentality, which is very typical. Community cohesion tends to be high. Then, unfortunately, what typically happens is that we proceed into what's called the disillusionment phase. And the disillusionment phase typically hits around 6 to 9 months post-impact for any type of disaster. During the disillusionment phase, the risk of suicidal thinking and suicidal attempts are typically at their highest. Not always, but usually. And unfortunately, the disillusionment phase with COVID overlapped with a bunch of different things in the United States: the federal election, the holiday season, daylight savings for states that go through that process, and then just fall and winter weather. So seasonal affective things as well. So this is not an official term, but I call that the trauma lasagna of 2020. It was all of the things happening within a 3 to 4 month period of time. It made it very, very challenging for us to manage through symptoms. Then we proceed out of the disillusionment phase and into the reconstruction and recovery section of disaster work, right? Unfortunately, what happened after that is that we had the Delta variant, and the Delta variant caused what we refer to as a secondary impact. And then Omicron came along a couple months later and caused a third impact. Now, those are just large scale impacts from the COVID pandemic itself. That is not to even include weather related things like wildfires or hurricanes or floods that occurred in many different parts of the country. So arguably, some places and regions and communities have had 4 or 5 large scale impacts within a 24-month period of time. That's what a disaster cascade is. It is one thing after the next that restarts the disaster response cycle. So every time there's an impact, you go through that same process again. There's another disillusionment phase, and all it does is it pushes out the recovery process. It makes the trajectory longer. It slows down our collective sort of reconstruction, not in a literal sense, but putting our lives back together, right? And it makes that whole thing take a lot longer than we would like, and we were expecting it to. So where we are right now, if we look at March is approximately 24 months. So we're right in month 23 here. And why I want to draw your attention to this is that people can be and are on any different pathway here. So we have many folks who are feeling fine or feeling like, I've got this. Like, you know, my life hasn't been maybe drastically affected. Things are going pretty well, like financially things, maybe I'm stable, I'm secure. Social relationships are fairly intact, right? And you have many other people who are on a very different behavioral health experience. Now, keep in mind here that on the y-axis, the higher you are, the better things feel, right? And the lower you are, that means the symptoms are stronger and the harder things might feel emotionally, mentally, and behaviorally. So nothing is exact here in terms of numbers. These are just general patterns. But where we are right now is at a strong and very significant point of divergence. And what I was mentioning previously about, you know, the capacity to help bring others to the resilience pathway, right? Resilience remains the most common outcome for any disaster, even disaster cascades. And disaster cascades have happened all over the world. In Haiti, after the earthquake in January, this was all within 12 months of 2010. They had the earthquake in January, they had a cholera epidemic in April, they had a hurricane in September, and they had election violence, very significant violence in November, all in the same year. And every time it started that cycle over and over again. So as you can see from this, I want to emphasize two things. Number one is that the experiences are varied. Some folks are feeling very strong. Some folks may be struggling with the other end of the spectrum, which is what we call kind of a chronic dysfunction in behavioral health. And in between, it can look like additional new symptoms, or it can look like additional new diagnoses that people have not dealt with before. So there's a wide variety of personal experiences, but the data remain clear that the end result does tend to be resilience for most people, the vast majority of most people. There is actually a wonderful article that was written, a qualitative article about resilience, speaking specifically about what we can learn about resilience from Haitians because of what they've experienced. Multiple hurricanes and lots of different pieces of adversity, some small, some very, very large and significant over the last many, many years. So yeah, check that out. Do a little search for resilience and Haitian strength. Okay. This is just something that I'd like to share with you to sort of level set where we're experiencing things from a provider perspective. So one of the things that I get asked a lot is, what's the difference between stress and trauma? And I'm guessing all of you know what that is. But in terms of explaining it to other people, one of the things that I find helpful is to just really orient around the idea that all trauma is stressful. So there's cortisol, our stress hormone, involved in every traumatic response to things, but not all stress is traumatic. So it's unidirectional, right? All trauma is stressful, but not all stress is traumatic. However, when we are exposed to moderate or severe long-term stressors, right? When our cortisol builds up to such an extent where there is such a thing called peak cortisol, right? You reach peak cortisol and then your brain it's not possible to process anymore. That can look in many ways, that moderate to severe long-term stress, just like a traumatic reaction in the brain. So our limbic system is highly activated. The fight or flight system is ready to go, kind of at the drop of a hat, for any potential threat that might be coming our way. And they look biologically and physiologically very, very similar. And where we are after at least, again, depending on where you are regionally, 3 large-scale impacts in a 24-month period of time is that most people's brains are functioning from at least a semi-traumatized state. Now, again, I'm using generalizations. This is most people. When we're looking at a bell curve, there are certainly exceptions. But in general, that's a big part of our neurological functioning right now. For behavioral health providers specifically, let's please not discount the experiences of secondary traumatic stress, or vicarious trauma is another term that's often used to describe it. We hear things all day, every day, during our working hours about what the struggles and the challenges, and in some cases tragedies, that families have been living through and experiencing that we haven't lived through, but we're hearing their stories, we're empathizing, and we're connecting with them, and that builds up onto our own exposure levels. It feels like, for many cases, and this is just a metaphor that I like to use, but it feels like for many of us, from a provider lens, that we're drowning in a sea of need from people, and we've got one life ring. I don't know what that exactly is, but we keep tossing it to each other, right? You can only have it for a little while, and then you have to pass it on because the resources are so scarce, whether that's staffing or budget or just your own personal time and sense of exhaustion. You might get a little bit of a break on a weekend, and then you feel like you're diving right back into it. So structurally speaking, the sense of overwhelm is very, very, very strong. The other thing is that we're going to talk about the traumatic brain and the different types of reactions and behavioral responses that people have to it. But a sense of heightened arousal to things is very, very common. And the likelihood of misperceiving other people's intentions towards us as being negative, threatening, or hostile, even when they're not. That's on one end of the spectrum. We'll talk about the other one in just a second. Another thing that's happening is the degradation of care. And this doesn't mean that people are doing a poor job at all. Degradation of care means that when you're in a large-scale disaster scenario, the scarce resources that are available require shifting in how the care is delivered. The staffing ratios might be changed, as they certainly have been in many hospitals all over the country. The expectations for time off, when you can take it and when you can't, and how many people are on a given shift. What are your backups and who are your other resources might not be available to you. So when we refer to degradation of care and disasters, we mean that people might be doing things that are outside their job role. They might be asked to fill in or take a role that they've never done before or that they're unfamiliar with. And this is part of what we know happens in healthcare settings in general. But one of the consequences of that is something that we call moral injury and also increasing in burnout, right? It's when people feel like there's way too much going out in terms of mental and emotional energy and not enough coming back to fill them up. And also that we have pretty extreme, in a lot of cases, feelings of anger or guilt or frustration or sadness because we can't do our jobs the way we want to because of the circumstances. So the degradation of care, the scarce resource phenomena are all things that are impacting provider mental health and well-being right now. Also, we face pressures and demands from all sides, right? Our families might need things from us. We need things from ourselves. Our clients need things from us. And there's this constant sense of managing depletion, for lack of a better term. Where am I managing my resources personally? And I also want to talk a little bit more about the brain stuff. There's a couple more slides on this, but the more time you can give yourself just to take a pause before you respond to a text message, to a colleague at the water cooler, to a stranger driving their car next to you who forgot to use a blinker, right? Somebody at the grocery store who, doesn't see your cart and kind of runs into you, whatever the case may be. If you slow down before you respond in any of those circumstances, you're likely to have a more fully developed and integrated neurological response, meaning that you're not going to be responding from your limbic system, that the prefrontal cortex is going to be involved. Again, more about that in just a second. The last thing I want to mention here is the fundamental attribution error, which is something that I'm sure many of you have heard of and are familiar with. But the reason why I'm including it is that the fundamental attribution error is something that, if we're aware of it and we can apply strategies to sort of counteract it, it can help us help each other collectively. So the fundamental attribution error is the tendency that we all have as human beings to look at what we consider bad behavior from other people. So when somebody's doing something that we don't like, we judge bad behavior, however we conceptualize that, as being a function of someone else's personality or character or disposition. We say that they're acting this way because that's part of who they are. But when we do something negative or bad, right, we tend to say that that's a function of our circumstances. Like we didn't get enough sleep, or the kids were acting up this morning, or there was something else going on that just made me act that way, right? But we don't extend that courtesy to other people. So the fundamental attribution error basically is that we attribute to others the wrong explanations for why they're behaving in ways that we might not like or appreciate. The reason why I'm including that is because when we recognize our tendency to do it, first of all, if you're aware that it's a thing, then you can be more conscious about how you're judging behaviors that are coming to you from others, and look for opportunities specifically for where the environment might be playing a role. It's like, oh, maybe things aren't going so well at home. I think one of their kids was out on a quarantine. That's got to be really stressful. That might help explain why they're so grumpy today at work, rather than they're just a grumpy person, right? So applying this sort of principle to our day-to-day interactions with people, I'm hoping can be helpful. So I was mentioning the brain and how strongly it is impacted. It's incredibly fascinating to me how the human brain responds to disasters. And there's a couple different things going on. The first thing is in the limbic system. So obviously when anytime there's a threat, right, whether that's a disaster or a small scale thing, the limbic system gets activated in order to perceive what's going on and then to release adrenaline to tell us you should run, hide, fight, whatever the fight or flight things are. The chemicals, epinephrine or adrenaline gets released. and it keeps us safe. The brain's job in a disaster is to keep us alive and to keep us safe. So what ends up happening at 24 months in is that for many people, the limbic system is very, very sort of highly active, like too active. It's in charge of people's responding. The other side of that coin is when people shut down and when their limbic system becomes so overwrought with whatever's going on that they numb out and they shut down and they don't participate in things. What we call this in disasters is acting out and acting in. And that term, it's not about behavior specifically, but it is about the way people express distress. And for people who act out, that looks like hostility, aggression, maybe illegal behavior, maybe substance use. That's expressing distress externally. And acting in is the opposite, whereby people pull in, they withdraw, they isolate, they shut down, and they don't participate in things even when they can. So your brain actually, it's very, very typical for there to be a bimodal sort of result where some people are more acting outers and some people are more acting inners. Obviously, that's not a technical term, but you get my meaning. So the limbic system is very, very directly involved with all of these things. But the other part of the brain that's kind of hanging out in the background is the prefrontal cortex. And that part of the brain is very, very necessary for everything at work, right? Thinking about consequences, considering what are we saying and what do we mean by it, all those details, tracking information, even processing memory to a degree, planning and organization, all of those things. Well, if you're in a prolonged survival mode, like a 24-month multiple impact large scale disaster, the prefrontal cortex doesn't really know how to integrate well with the rest of the brain. So it's there and it's functioning, but not very effectively. And the consequences of this is that most people, I wouldn't say adults, but that's true too, feel like they might have symptoms that are similar to ADHD, right? Maybe for the first time in their lives. And it's better maybe now for some folks than it was 6 months ago. But the cognitive brain fog, COVID brain, I joke with some of my folks at the Department of Health that you need to have at least 2 people on any project so that between the 2 of them, there's one functioning brain, right? You have to share a brain with your work buddies because people's brains are compromised right now in some form or fashion. And that's not true, of course, for everybody, but it is true for most people in general. So yeah, if you also have trouble paying attention and focusing and you can't remember if you hit send on that email, you're in very good company for sure. I'm going to switch gears I'm going to stop there. Gabriel, can you go ahead and launch that next poll about grief and loss? We're going to switch away from neurology to grief and loss. So this slide or this poll is asking, how prevalent have you found issues of grief, loss, and bereavement to be in your current work, either personally or professionally? And we'll wait just a minute to get some answers and then we'll move along. Looks like 65% of folks are saying it's very prevalent in their work, and about 34% are saying moderately prevalent. So it's definitely showing up for most folks. A few folks are saying not at all, but that doesn't seem to be the majority. It looks like we've got good participation in this poll so far. Thank you for doing that from wherever you may be. Yeah, the numbers are staying pretty consistent. So 63% are saying very prevalent in their work personally and professionally, and 35% are saying moderately prevalent. So it sounds like it definitely is something that's coming up for the vast majority of folks. And it's something that we're managing personally, but also that we're seeing it in the workplace. Tip one of those 2, right? Good, thank you. Okay, oops. I'm trying to shut that. There we go. Thank you. So I'm gonna transition into some discussion about this, and I really encourage people to keep an open frame of reference about what we were talking about at the very beginning. That this is not necessarily about the direct loss of a loved one, but for many, many people it has been. And whether that was directly with COVID, or whether it was just an accident or an injury or an age-related thing that happened just in the context of the pandemic, many, many people have lost someone. And I wanted to include this slide because I think it's just some really helpful insight. This has been aggregated from some grief and loss work that I've done over the last several years. One thing is that even when things are happy, so a holiday, a birthday, an event of some kind, when people are supposed to feel celebratory, there is still an awareness that someone is missing who should be there. Small talk can feel painful because it feels so superficial and meaningless sometimes. Grief can be very awkward, right? Even, or especially with people who know you well, because they just want to care for you, but they don't really know the best way to do it. Emotions are all over the map. It comes in kind of two different types of styles. One where you just become overwhelmed with emotion when you're absolutely not expecting to be, like watching a commercial on TV or driving past a particular place. And then sometimes when you're in a condition where you expect yourself to feel a certain strong emotion, but you don't, right? So all kinds of different things. And then coming in waves, right? Days and weeks when you might feel like, okay, I got this, like it's okay, it's manageable, or even feeling pretty good. And then other days when it's like it just happened and you're reliving things all over again. So lots of grief and loss experiences for sure. Okay. Losses of relationships. Yeah, I'll talk about that in just a minute. So this is a graph that actually is something that I developed with some of my students at Seattle University. And I think it's really helpful when we're considering how to provide care. The idea with this is that I recognize and acknowledge fully that with COVID, it's never as simple as a nice little chart like this. Like the losses folks have accumulated over the last 2 years means that there's multiple bubbles and graphs and charts all overflowing with each other. And what I wanted to include, the reason why I wanted to include this is because I want us to try and be mindful as much as we can about when we are having a one-on-one personal interaction with someone else. We need to try and figure out which direction the comfort is going, right? It needs to be, as much as is possible, unidirectional. So it's about providing comfort towards the center of the circle, toward the person who is most directly affected, and allowing that person to express their distress out. The takeaway point here is that you don't want to put the person who's at the closest center to the circle in a position of comforting you, right? It doesn't go the other way, or at least ideally it shouldn't. And recognizing that all of us have had some degree of loss, what I would urge you to consider is that for that particular interaction in that moment on that day, which direction does it flow, right? It's not that you aren't deserving of comfort or that you don't need to express distress also, because that's not the case. But it's just being aware of, for those specific and individual interactions, which direction should the comfort and distress flow, and not make it unidirectional. Other considerations in general. We really want to help clients. Now, this is kind of on a professional lens for making impulsive decisions. And what I mean by that is that, I'll just give you an example. If somebody says, well, this just happened to me, I'm going to sell the house, sell the car, and move to, halfway across the world, just change my whole life, right? Quit my job. It's helpful not to just naysay that, even if you think it's a terrible idea, right? But to say something akin to, if you still feel that way in a month or two, then I will, I'll have your back. But I really want to encourage you to wait at least a few weeks to a month and reevaluate to see if you still feel the same way then. If you give people time, their perspective tends to change. And it doesn't mean you can't support whatever the decisions are that they decide to make. Big decisions aren't bad, but big decisions that are made impulsively tend not to work out as well. So I'll say that again. Big decisions aren't bad. Big life-changing decisions aren't negative in general, but big decisions that are done impulsively tend to not turn out as well as those that are thought through. And that usually just takes time. Another thing I'd like to add here is, and this is on a personal level, so switching hats from professional to personal. If you are trying to support someone who's grieving, rather than saying, and I'm guessing everybody on this call has said this at some point, let me know how I can help you, right? We all say that. I've said that. Everybody says that. Let me know how I can help. But when we do that, it puts the onus on the grieving person to come up with something, right? Sometimes it is a lot more helpful to offer a discrete and very specific task. Can I drop off some groceries on your front steps? Can I bring you a hot meal? Can I take your kids to the park for you? Can I run an errand? Get the oil changed in your car? Like, that's a random one, but you get the idea, right? Offering a discrete task that you have time for and that you think might be helpful to them gives them the opportunity to say yes or no to that, right? But it's oftentimes more helpful than saying, let me know how I can help, when that person might not even know how they need help. But if you offer a concrete task, then they can say yes or no to that. We're going to talk about active listening, which is something that I'm sure all of you are familiar with. But nope, yeah, I'm gonna go ahead and do that right now. Obviously, as a behavioral health intervention and technique, active listening is one of the most important and helpful tools in our entire toolbox. Meeting another human being where they are and engaging with them with the intention to understand and care rather than to fix something or problem solve something, that is where a lot of meaningful work happens, right? Starting with those open-ended questions, asking people if they're okay. Now, there are huge cultural differences about grief and loss, about where the appropriate lines are. It's generally okay to ask if you don't know, right? But to use that active listening to for a different purpose, right? You're not trying to make them feel better or to fix something that you can't fix. But active listening is helpful because it allows the person who's speaking to work through on their own terms and time some of the experiences that they've been having. And that's one of the reasons why it's such a powerful intervention, right? Okay, I'm going to share with you a model that I developed called the HEAL model, which tries to summarize just important things to keep in mind through the grief and loss process. So we've talked about this previously. One of them is that loss is not just about the loss of a person. It can be the loss of identity, the loss of meaning, the loss of an idea or principle, a shift in worldview because things got upended, loss of safety or security, that kind of thing, right? Lots of different types of losses. So we're not comparing, and we're certainly not using a justification or a rationalization that certain losses are worse than others, because that's not the case. Oops, I got stuck there. Okay, so the H in the HEAL model stands for honoring the loss. This is one of the first considerations. This is one of those that has been really, really upended by the specific types of things that we've been asked and required to do in COVID, right? Not gathering, not getting together for a wake or a funeral or certain things like that for large chunks of time. So there are many, many, many people who are trying to identify or have not had the opportunity yet to figure out how to honor the losses that they have experienced. This is not the same thing as being okay with it or making a positive spin on things. This is about participating in the recognition that something has taken place, right? So it's a ritual, a ceremony, or another tradition, culturally variable depending on what that community is, and it's going to look different everywhere. But it's about not avoiding and ignoring the losses that have taken place, for sure. The one thing else I want to mention on this that's not in the slides is just that it's really important to include children. I know I mentioned that at the very beginning, but children need to be included in honoring losses in a direct and developmentally appropriate way, and not kept excluded from things based on, of course, based on whatever cultural norms are typical. But I think a common mistake is to hide things or even lie to children to protect them. And oftentimes that's not the helpful tack to take. The E in the HEAL model is about expressing emotion, and anger is a bodyguard emotion. Anger protects us from feeling a lot of different other things. Anger neurologically is very, very easy to access. It's right there on the surface, and anger is more socially acceptable than other emotions, right? It's what we call an externalized emotion. So I can be angry with you or them or some situation that's outside of me, right? But it protects us typically from feeling other things that are more challenging, like sadness and fear. So anger is something that we see all the time. But if we use active listening and we really try and understand what someone's experiences is, chances are that we can uncover there's a different type of emotion that is being managed underneath that's a lot more uncomfortable for people. So sadness and fear are internal, which means that it's harder for us to express those things outside of ourselves. And that's why it comes out as anger, or it tends to, it can, not always. There is a tendency for people to be angry towards the person that they have lost, if they have lost a loved one, and then feel guilty about being angry. So it's just sort of normalizing and recognizing anger can be motivating. It can be helpful under certain circumstances. However, right, anger typically is not the be all end all of that emotional expression. There's usually something else that's driving it underneath. And sometimes if we use those active listening techniques, we can find out what's happening. That's sort of the catalyst for it. For the A in HEAL, this is about acknowledging the obstacles. And all I want to say about this one is this is the but if then that we might find ourselves saying on a regular basis. But if COVID hadn't happened, then they would be here. If they had been vaccinated, this wouldn't have happened. If they had just not done this thing, or I don't even know. I can't come up with another example, because it doesn't even have to be COVID related. But if you find yourself saying, but if then you're staying stuck in the acknowledgement that something actually just did happen. So the psychological point of intervention with that is to remind yourself, but it just did. So if you notice in your head that you're saying, but if I had just, or they had just, right, then you can say, but it just did. But it just did. And I understand that that's overly simplistic, but that technique of interrupting this but if then process allows your brain and your body to kind of process through things rather than to continue to stay stuck on a future and an eventuality that can't take place, right? Lots of different ways that this looks for people, but the if thens are common. And then finally with HEAL, it's about living. It's about starting with just breathing and getting up, and maybe not even getting out of bed, just literally one day. And it starts with survival and existing, and then slowly transitions into active living again, reconnecting and engaging. Everybody's timeline for this and how that looks is very, very different. It depends on the type of grief, the severity, and the intentional and active development of resilience can help with this, but there's no specific timeline in terms of the way that this looks. Sometimes it takes folks a long time to reconnect and to re-engage in active living, but that is a part of the process as well, which is why I included it in the model. So I'm going to switch gears again. Gabrielle, can you please launch the final poll? So this is about how would you rate your own personal capacity on modeling resilience and vitality for your team? Where are you with your sense of capacity, your personal capacity? Recognizing that, some of the suggestions that I'm going to make on just the next couple slides are intentionally, they're not meant to add more to your to-do list, right? This isn't about digging deep and finding more energy when you just might not have it. This is about sort of thinking more strategically in a different way, but not doing more stuff for sure. Okay, it's looking like 67% of folks, 66, 67% say moderate capacity. 6% are saying, nope, no, don't have it right now. That's okay. And then about 28% are saying, about 30% are saying high capacity. Yeah, that's great. Wonderful to know. Looks like most people have answered it, I think. So we're sharing the results here. 5% are saying not really having the capacity right now. About 67% saying moderate capacity and 28% saying high. So that's good. What I would just encourage you to do when you are in a moderate or high capacity is to just really be aware of when you can apply those things. Like when I have a little bit extra to give, how can I do that? Because that's part of our collective movement on these pathways, these resilience pathways. Okay, thank you. We're going to go ahead and close that. I just want to make a recommendation. If you haven't done this already, this is as simple as just one piece of paper that you stick on your refrigerator. And you can call it whatever you want. I call it a personal coping plan. There are apps even that do something similar to this, but you write down what your primary concerns are, right? What are the things that you get bogged down with? Is it anxiety? I mean, I just use these as examples, right? These are not specific recommendations. These are just examples of things I talk about with people in here on a regular basis. So you identify the issue that is the most important for you that comes up. And then what are your personal options? What works for you, right? So oftentimes with anxiety, sensory interventions are helpful. So ice cubes, putting your hands in cold water, taking a hot or a cold shower, listening to a playlist, like those sensory things, right? For hopelessness, connection helps often with hopelessness. Pets or helping the neighbors or something bigger than yourself, like reaching out beyond you to connect to good news and good things that are happening. And then when does it work? So break it down and be as specific as you can. And identify also who are your people, right? What are your sources of support? This can be external resources and internal strengths, however you want to kind of frame it. But the idea about getting it written down on a piece of paper and sticking it on your refrigerator or wherever, right, is that it's concrete. You've thought it through. And when you have a really, really bad day or a bad week, you have it right in front of you and you can just pick something that isn't some random person's idea of what should help you, right? It's not my idea, not somebody else's idea. It is what you know works for you, and you can just try it depending on how much time you have. So the list should include ideas that are helpful for you that take anywhere from 5 minutes to 5 hours or somewhere in there, right? Various varieties of things. I'm going to just give you 2 more slides before we finish up with some Q&A today. Part of what helps us identify vitality and reconnect with vitality is when we orient to the things that matter the most to us as people. And in the last 2 years, we have been operating so much in emergency management mode in our brains and in our heads and hearts that it is very, very challenging to reorient and ground ourselves in those foundational values that make us who we want to be, whether that's as a provider or just as a human being. So I would encourage you to think, and you can write this down if you'd like also, what is 1 or 2, and 5 if you're at high capacity, right? Key core values for you personally. I'll share the 2 that I'm focused on right now are gratitude and patience. Those things are very important to me and I struggle with them. And so pick one, right? You can just pick 1 or 2, however you want to structure this. That's the highest priority for you. What is the value that you want to focus on developing for yourself? It might seem on the surface like it's more work, but let me tell you, if you're focused on that value, like I'll just take patience, for example. If I focus on patience when I interact with my kids and when I interact with my clients and when I interact with my colleagues at work, all of those interactions go better. And I have a little bit more energy because as I'm interacting in a way that is consistent with patience, it feels better. It feels like it's more successful. It feels like it's more consistent and genuine with who I really want to be. And that's a better day, right? Even if things that happen in the day go sideways, if I'm focused on that value as I interact, it's generally going to tend to go better. So it's not more work, at least it's not supposed to be. And then pick an example for yourself about how you can practice it or manifest it in the workplace and then also at home in a personal context. Just making a list and getting started in this direction is going to help sort of orient. It's like, okay, 2022, step by step, little by little, how do I develop the kind of person that I want to be as a human being? Great examples coming up in the chat right now too. And then finally today, I want to give you one more model that summarizes some tips for how to reduce compassion fatigue that I think many of us are struggling with right now. The first thing is to build in positive reinforcements. The trick is that the rewards and the reinforcements have to be healthy, right? If you have a glass of wine on a Friday night, but the glass of wine turns into a bottle of wine, that crosses a line to become maybe a less than healthy reward, and then it's not reinforcing. Or it is, but of the wrong thing. So we really want to be aware that rewards are the right size. I've shared this example before, but it's worth a repeat briefly. I worked with a woman who had a box of chocolates on her desk, and every time she would do a meeting that she really didn't want to do, she would treat herself to a chocolate from the box on her desk. That's great if you have the kind of self-control that allows you not to just scarf the whole box of chocolates. I do not have that kind of self-control, so I could never have a box of chocolates just sitting on my desk. So different rewards work for different people is the point there. The second one is to establish boundaries. And this is something that we all struggle with in our work culture. is saying no and having off-duty hours and being unavailable for things. But when we work on it with each other, we can change our culture around this. The third thing is to share our concerns, not isolate, but to continue to participate in things and connect with people, even when you don't really want to do another Zoom happy hour or whatever. And then the last one is to trust. There is a myth of indispensability that I think most providers carry, and it's a myth for a reason. It says that you're the only one who can possibly do this job for whatever reason. And we need to trust each other a little bit better and reach out and ask for help, and not be afraid to say, I just can't right now, and I need some support from other people. And if we do that collectively, we can advance the ball a lot farther. So I think that's everything. I'm going to just leave you with these ingredients of resilience, but you all have the slides. These are the things that we've been talking about all day today: motivation and purpose, connection, the options to adapt to changing and unexpected circumstances, and hope. Hope came up in the chat a lot today. And I do want to acknowledge that hope is the one of these ingredients that is the most tempered by sociocultural experience around discrimination and racism. So it is easier often for some people to experience hope than for others based on the cultural and social experiences that they've been through in their lives. Okay, I'm going to jump into the questions on the Q&A.
Oh, great.
Christina, did you want to read them? Or
Yeah, we'll read them. And just a note, Gabrielle has put the eval link. I know some have maybe had to leave, but if you have to leave early before we get this, want to make sure you can do your little evaluation. Okay, back to the top of the questions. We do have a handful. So first question, what is your advice for frontline behavioral health staff who are getting burnt out and disillusioned and struggling with high workloads due to lack of staffing? Because we know that was an issue before, it's worse now.
At the end of the day, you can only do what it is you can do. And it is mission critical. It's not optional to have your vacation and to have your weekends and your time off. You can only serve the rest of your clients or the next client if you have a chance to get away and come back. So that means things aren't going to get done. Objectively, things aren't, but it is essential for people to do only what they can and focus on the value of what you can do, and then do the same thing the next day. Because when you step back and look at too big of a picture, it becomes completely overwhelming. It's the example of the starfish on the beach, with a big storm that tosses up the starfish, and there's 10,000 starfish on the beach, and the behavioral health provider in this case is walking along, tossing one at a time back into the ocean to save them. And a child comes up and says, why are you bothering with this? You're never going to save them all. And that person picks up the next starfish and says, but it matters to this one. Then tosses it back one at a time. That matters. And that's how we have to stay focused in this work.
Yeah, great. So another question, in your field, is grief normally thought of as an emotion or as a state of being that includes various emotions simultaneously, anger, remorse, fear, that could even include positive emotions, such as relief or moving into a new phase or anticipated losses, that kind of thing?
Yeah, I mean, the short answer to that is both. Psychology doesn't look at grief as only an emotion, for sure. It looks at it as a state of being as well. Yeah.
Okay, so I know the chart of the disaster emotional highs and lows was very impactful when I first saw you do that. Showing 1 year and after that 1 year. How about when it continues on past a year? Maybe you spoke to that, but I think it might be helpful to talk about, that time frame. What does it look like when there are repeated waves and it's not done yet?
Yeah, I mean, so a disaster cascade effect pushes out the recovery process, but the research on multiple years of disaster cascades still shows that the eventual, we're thinking 5 to 10 years down the line, right? The eventual long-term outcome for the vast majority of people is still resilience. So the complexity and the length of COVID as a disaster is somewhat unique, but multiple impacts over 2 years or 3 years is not actually that unusual. So I have every confidence that we'll still get there. It's just going to be a longer hill than we thought we were going to have to climb.
All right. Thank you. Okay. This is very crucial. We spoke on this earlier, but just briefly, what are organizational supports that might exist out there for staff, especially staff of color who have more personal impacts?
That is a great question. And it's going to be very dependent on what the local and regional resources are that are available through your agency or community. I'm not able to answer effectively, really. I know MHTTC has a lot of amazing resources that they are offered nationally, but in terms of specific organizational supports, I think it's very helpful for supervisors to focus on connection. People will still do really, really tough work under really, really tough conditions when they feel connected to the people that they're working with. So I think it's helpful organizationally to focus on connection as a way to address that, for sure.
So, and I don't actually know the answer. I would have typed it for this question. Have you published the HEAL model? Now, I will say, having seen a lot of your work before, you love your acronyms and they're so helpful because it does help us remember. So is there something published out there that we should list in a resource, or is it just one of your many presentations that you have?
Yeah, I do. I mean, the model itself hasn't been copyrighted, but I don't have an article that I can point you in the direction of. I would say that the behavioral health resources page for the Washington Department of Health has lots of my models in it because I've kind of donated them to this cause. So yes, there are links that if you look at behavioral health resources for the Washington State Department of Health, you'll find all of my models there.
We'll make sure to note, Gabriel, we do a resource, Q&A page, and we'll make sure that page goes in there because I know that has a lot of your stuff. Okay. So last question before we do our little exit slides. How do you identify what time frame works best for you or your client for the personal coping plan?
So the time frame really is about how much time you have available, right? If you only have 5 minutes to engage in an activity that you know is healthy for you, then what are your 5-minute options, right? So it's coming up with a list of reasonable options for your windows that you might have available, whether those are on the evenings, on the weekends. Like I like to bake and take things to my neighbors, and I can only do that on the weekends. I don't have time for that during the weekdays. So about just evaluating where your schedule is for what strategies you can engage at different times is all. Yeah.
Mute. Here we go. So we do have one last question just at the tail end, and then I got to get to the outgoing slides. But what tools, resources are available to understand more how to address misperception of threat from others, sort of assigning that motivation due to long-term stress or trauma? That might be something that we have to have you send us an article or something, but please take a minute if you can. I think that's a huge factor right now. Everything is so tense. You walk out the door, you're driving anywhere, it's pretty rough. Everyone's in a real rough state.
Yeah, I would start with just looking at research on trauma-informed care. If we have a trauma-informed lens that we're looking at it with, it really helps. There's just lots of good data and research around about how to do that from a professional level as well as personal. So I would start with that.
Yeah, I in that vein, I remember hearing the phrase that will always stick with me. Yes, thank you, Lindsay. Trauma Stewardship, great Northwest author. What happened to this person versus why are you acting this way? It's been said 100,000 times, but that is just a helpful mantra. So, Dr. Massa, thank you so much. I know we could literally have you here every week, and we might have to talk about that, but people are just loving this information. It's so resonant, and we just thank you for your time. Want to make sure folks can see, the eval. We're starting to use some QR codes. Hopefully you're getting the right link. But we really, really, if you like this or you didn't, tell us. We actually read every single one, not separately, but we collectively read the feedback. And it's really, really helpful for our speakers. On this topic, the network, and we are supporting the second Grief Sensitivity Virtual Learning Institute. So the first day is for general mental health. Second day is for school mental health. We can hopefully get the link in the chat, but that's a great day of information and great speakers that study and do this work specifically around grief. I know we're at time. If you want to connect, feel free, please. We'd love to hear from you and connect with you. Thank you, Gabriel. And thank you so much for joining us. And we'll see you next time. Dr. Massa, any parting words, as I know we're out of time.
No, thanks, everybody. I appreciate all of the great work that's being done. It is just one interaction at a time, for sure.
And thanks to all of you for taking time today when you probably didn't have it, but I hope this fills your cup a little. And, we have to do that as well. So thank you for all the work that you do, and we'll be thinking of you, and we'll see you next time.